Okay, so hi everyone, welcome to the UBC Plastic Surgery Interest Group October Journal Club. Today we have two very interesting topics that we have aligned for everyone who's in attendance today, but also to whoever who cannot make it but is interested in learning about the topic. We have this recorded so you can view this afterwards. And just a brief introduction. I'm Helen. I'm one of the research and education co-director for the UBC Plastic Surgery Interest Group this year. And Margit, do you want to kind of introduce briefly yourself?
Hi, yes, my name is Margaret. I'm in second year at UBC and I'm on the fundraising team for the Plastics Interest Group.
Yeah, so the first topic that we're going to talk about is breast reconstruction. And Margaret will be talking about cleft palate, both of which are two of the bread and butter of plastic surgery. So we're very happy that you can join us today for two very important topics. And hopefully you can learn something out of this session. So let me go to the next page. Margaret, are you on the same slide, like slideshow?
Let me check. Am I not supposed to be? Or
Um, I'll edit this out later, but let me see. Oh, there we go. Okay. So sorry about that. So what is breast reconstruction? Um, this is a procedure that the main goal is to restore one or both breasts to near normal shape, appearance, symmetry, and size following mastectomy, lumpectomy, or congenital deformities. And there are several reconstruction methods, one of which is implants. The second one is autologous tissue, which is from another part of the body. It could also be a combination of implants and autologous tissue. There are also variation for the timing of the reconstruction. So it could be immediate reconstruction during mastectomy. It could also be delayed reconstruction after healing and cancer treatment, which can occur months or years later. And nipple and areola can also be recreated in a later reconstruction stage if these were not preserved in the original surgery. And if you have larger breast, you may also have surgery on the other unaffected breast to balance their appearance. So first, we're going to talk about implant-based breast reconstruction. So after a mastectomy or breast conserving surgery, implants are placed either under the skin or beneath the chest muscle. So the surgeon will create a space or pocket to position the breast implant, which can be placed either over or under the chest muscle. And the implant itself is a round sac made of silicone rubber filled with either sterile saline or silicone gel. And in Canada, silicone gel implants are more commonly used. And there are several techniques to create the pocket. One of which is tissue expansion or tissue reconstruction, which is more common, and the other is direct to implant reconstruction. So tissue expansion is if the skin and tissues in the chest are too tight or flat for the surgeon to place the implant under the skin or muscle, they will need to make the space larger. And an expander implant placed either during or after a mastectomy is gradually filled with saline over several visits to stretch the skin and create space for a breast implant. And once the skin is sufficiently stretched, a second surgery is performed to replace the expander with a permanent implant, typically a few months later. And the other technique is direct to implant reconstruction, which is done less often than tissue expansion, but it could be an option if you don't have enough tissue available on your body that can be used to make a breast. And this could also be called a single stage breast reconstruction because it can be done in a single surgery. And instead of first using an expander implant, the surgeon will place a breast implant during a mastectomy or breast conserving surgery. For direct-to-implant reconstruction, the surgeon commonly uses a cellular dermal matrix, which is a graft made from donated human skin tissue. And basically, they will stitch the acellular dermal matrix to the chest to create a pocket for the breast implant, which can be placed under or over the muscle, and it may also cover the implant edges. And the acellular dermal matrix will act as a supportive scaffold to help hold the implant in place while allowing blood vessels from the body to grow into it, and so integrating it over time. There are several possible complications from it, one of which is capsular contracture, which is scar tissue around the breast implant, which can make the breast feel hard and loses its shape. The implant can also move around, or it could become wrinkled, or it could leak and also break. So the next technique is autologous breast reconstruction, where the surgeon creates a flap from tissues in your body. And the flap is usually taken from the abdomen, but can also come from the back, buttock, or thigh. And the flap itself consists of blood vessels, skin, fat, and sometimes muscle. It has a more natural feel than an implant, and the flap itself could be pedicled or free. So a free flap is called a free flap because the surgeon completely removes the flap from the blood supply. And then it places the flap on the chest and attaches it to the blood supply there. The pedicle flap keeps the tissue attached to the original blood supply, and the surgeon tunnels the flap under the skin to the chest to rebuild the breast. So there are several types of flaps used to reconstruct, used for the reconstruction. So the first one is a tram flap or a transverse rectus abdominis muscle flap, which uses muscle, fat, skin, and blood vessels from your abdomen to reconstruct the breast. And the area on your abdomen is then repaired with a special mash to restore the strength of the abdominal wall. And we also have a DIEP flap, which is a deep inferior epigastric perforator flap, which only uses fat, skin, and blood vessels from your abdomen. So unlike a TREM flap, it does not take muscle from your abdomen. The last one that comes from the abdominal or back is a latissimus dorsi flap, which is also called a back flap. So it uses the latissimus dorsi muscle, fat, and skin from your back to make a mound to rebuild the breast. And an implant can be used if there isn't enough tissue to make a natural looking breast. This type of flap is used if you had radiation therapy to your chest or if you don't have any extra skin and tissue on other areas of your body that can be used for breast reconstruction. So I have like a couple of diagrams here. Hopefully it's clear and you can kind of see how that might be, how each of the flap can be done. And unfortunately for this type of technique, there could also be several possible complications, including hernia, and the reconstructed breast could also have a slightly different color and texture compared to the surrounding area. There could also be reduced back muscle strength if the tissue was taken from that area, and there could also be necrosis of the transferred tissue. And nipple and areola reconstruction is the final step of breast reconstruction if during a mastectomy or any breast conserving surgery, if these two are removed. And surgeons can reconstruct them for a more natural breast appearance, typically as the final step of this process. And this is often an outpatient procedure that is done once the breast has healed, usually 3 to 6 months post-surgery. And the tissue for the reconstruction often comes from the new breast or other areas like the chest or earlobes. And a medical tattoo artist can also match the color to the other breast using a 3D tattooing technique. And since the reconstructed nipple has reduced sensation than natural ones, some patients may also choose just tattooing alone without the nipple reconstruction surgery. And There are also another patient population where they will have nipple-sparing mastectomy, which could be an option for some. They won't uh, require this nipple and areola reconstruction. The last topic I kind of want to touch upon related to breast reconstruction is breast neurotization. So sensory innervation to the breast comes from the third, fourth, and fifth intercostal nerves, and these nerves are often cut during mastectomy, causing painful neuromas or reduce or loss of sensation in the breast and nipple areolar complex. And although the sensation can gradually return to some extent, it is usually less than before the surgery. So breast neurotization is a surgical technique aimed at restoring sensation to the breast by connecting the chest nerves or the donor intercostal nerves from the abdominal flap to the recipient intercostal nerves in the chest. And this procedure has been shown by several studies to encourage nerve regrowth and potentially improving sensation in the breast and nipple areolar complex area. And patients this process undergoing this procedure may experience increased nipple sensation through this process. And this could lead to earlier sensation return and also increased sensitivity to pressure. Which brings us to the article that we want to talk about in this journal club, Sensory Outcomes After Neurotization and Nipple-Sparing Mastectomy and Implant-Based Breast Reconstruction. This is a study done by a group at Stanford University School of Medicine. And this group actually have published a prior paper back in 2019 where they reported early outcomes from a novel surgical technique they designed to improve sensation following nipple-sparing mastectomy and implant-based breast reconstruction. And since then, since 2019, after they published that paper, other groups have utilized similar approach and conducted smaller studies with similarly encouraging results. So what this current study plans to do is, or what this current study aims to do is to expand on that previous work by examining a larger patient population and extending the follow-up period and utilizing more comprehensive outcome measures, including using sensibility assessments with the Acroval pressure specified sensory device. So in this study, between May 2019 and December 2021, so within a 2-year period, 207 women had nipple areolar complex neurotization during nipple-sparing mastectomy with acellular dermal matrix-assisted breast reconstruction. And the nipple-sparing mastectomy was performed in all patients and involved preservation of lateral intercostal nerves when the anatomy was favorable. But when the nerves could not be preserved without compromising the oncologic safety, the nipple areolar complex neurotization was performed using allograft or intercostal autograft from a transected T3, T4, T5 lateral intercostal nerve to the identified subareolar nerve targets. And after that, immediate prepectoral direct-to-implant reconstruction was then performed. And sensory testing was conducted pre and post surgery at 6 and 12 months using a pressure specified sensory device. And several pre and post operative neurosensory testing data were collected. These include 1-point static pressure threshold and also 1-point moving pressure threshold. And these pressure thresholds were measured at multiple breast locations, which I will show in the next slide in the result in our discussion of the results of this paper. And the sensibility outcomes were categorized from excellent to failure based on the pressure thresholds. And so this is the result that I was referring to earlier. At at the end, only 47 women or 79 breast out of the 207 women completed neurosensory testing at least 6 months post-surgery. The overall rate of major complications, such as infections, wound issues, or the need for additional surgery, was quite low at 2.5%. But more importantly, the main findings that this paper was mostly focused on is the sensibility testing. And they did find that sensibility improved across all breast areas, and especially in the superior quadrant. So 6 months after surgery, the majority of the patient had excellent sensory outcomes. And by 12 months, the sensory outcomes improved even further, with 75% in the excellent range and 21% in the good range. And sensibility tests by the breast area, which are the graphs are shown here, show that most areas had excellent results in around the 59 to 66% of cases at 6 months. And with the upper breast performing even better at 88%. And by 12 months, these results improve across the board with up to 92% in the upper breast testing as excellent. So similarly, the other test that they have is the sensory measure or the static pressure threshold, which is shown on the right side. It also showed that at 6 months, between 22 to 62% of the breast had excellent sensation. And by 12 months, these numbers even improve even more, with 38 to 75% achieving excellent sensory outcomes. So overall, they do show that both movement and static pressure measurements have improvement over time. And importantly, no patients who were followed for more than 6 months reported chronic pain or post-mastectomy pain syndrome. And here's a different statistical analysis that they did. Since I think we have a couple of time, I'll just briefly go over it a little bit. For this graph, they use a mixed effects modeling method to analyze sensory tests for patients who returned for testing at all the time points. And there were several factors that affected the results, including time after surgery, age, initial sensory ability, and the specific area of the breast being tested. But for a typical 45-year-old patient, the highest loss of sensation was observed 6 weeks after the surgery, with noticeable improvement in sensation between 6 weeks and 6 months. And further improvement was seen between 6 and 12 months, but at a slower pace. And again, the upper breast area consistently showed the best sensation throughout the testing period. And so this slide was showing the moving pressure, and this is showing the other measurement they had was static pressure. And it showed a very similar, it used the same mixed effects modeling method, and it showed a very similar result. So for a typical 45-year-old patient with initial static pressure of 8.5 grams per square meter, they have a similar trend in sensory improvement across all the tested area. And there was a wider range of sensation between the different areas, but overall, the sensation values were slightly higher compared to the moving pressure results. Okay, so after all of those statistics, here comes the discussion of what those results mean. And so the author showed that the operative technique that they designed have higher breast and nipple areolar complex sensation levels compared to traditional nipple-sparing mastectomy and immediate reconstruction methods. And the sensibility improved significantly again in the first 6 months, but slower and between 6 to 12, and has specifically shown better improvement in the superior breast region. And the moving sensation recovery was better than the static sensation recovery. And they also interestingly showed that neurotization may potentially help reduce the incidence of neuropathic post-mastectomy pain. There are some limitation to this study. However, such as there were no control group without neurotization was included, but they offered all patients neurotization to preserve their sensation based on their positive pilot study results. And another limitation they have is that although the techniques evolve over time, such as the technique for nerve preservation and use of autographs, but these were not formally analyzed. And this study was also conducted during around the COVID-19 period. So there were limited in-person follow-up, which could affect the neurosensory testing. And lastly, the same surgeon performed both surgeries and the post-operative test. But the author believed that using the patient-reported pressure-specific sensitive device results minimize these potential bias that could be there. So that kind of reaches the end of our discussion of breast reconstruction and this paper. So hopefully it was informative, and here some takeaway from the paper. If all of the graphs and statistics were confusing, hopefully this slide would kind of summarize the main points from this paper. So Margaret, do you want to start with your presentation, or do we want to do question or discussion first? Sorry, I should have asked at the beginning of this presentation.
We can just see now if anyone has questions regarding your presentation.
Okay, sounds good. Does anyone have any thoughts or anything they want to discuss about breast reconstruction or the paper itself? I know there are some people in our audience that does research in breast reconstruction. So if you have any insights to offer, the floor is yours. I'll give it like maybe like 5 minutes, and if there's nothing to discuss, then we can talk about our next topic, which is also really interesting. It's cleft palate.
Yeah, I think we can just start going in with
Okay,
my presentation.
sure, sounds good. I'll change the slides for you. Just let me know when you want me to go to the next one.
Sure, thanks. Okay, so my name's Margit, and I'm going to be giving a short talk on cleft palate. So, giving an overview of the topic, and then just like Helen's presentation, I'm going to talk about a specific journal near the end. Next slide. So, what is cleft palate? Cleft palate is a congenital anomaly, also known as a birth defect, that occurs during week 6 to 11 of fetal development. And it's essentially a gap or an opening in the soft or hard palate. And sometimes it can extend to the gums and to the lips and also to the nostrils. The causes are varied. There isn't one thing that's known for sure to cause cleft palate, but there are some thoughts that there are genes linked to it. There are syndromes such as Down syndrome that is linked to it. Some anti-seizure medication and ondansetron used by the mother during pregnancy has been linked to it. Malnutrition, for example, folate deficiency, chemical exposures, smoking, alcohol, maternal obesity, and an amniotic band sequence can also cause cleft palate. And this is not a full list. There's many other thoughts out there as to what can cause it. And the diagnosis is pretty straightforward. It's visual or through the neonatal oral exam, in which the practitioner will stick their finger in the infant's mouth and just feel around for any gaps. Next slide, please. So the epidemiology is that it's relatively rare. So one out of 1,700 born with isolated cleft palate, and it tends to affect females more than males. And then with cleft lip and palate, that's about 1 in 1,600, and that affects males more than females. And when it comes to unilateral cleft palate, usually it happens on the left side. And treating cleft palate is really important because there's various complications that happen to the infant. Um, because there's that gap in the palate, there tends to be an opening between the nasal and oral cavities, so suction can't be formed while suckling or breastfeeding. So that leads to feeding difficulties and later on developmental or growth difficulties. There are specialized bottle nipples that are created for cleft palate, but of course, they're not always 100% successful. And there's also speech development problems that happen because of that lack of closure in the oral cavity. And children with untreated cleft palate tend to become hypernasal in their speech and have really hard time saying consonants. And also because the nasal cavity isn't closed off in a proper way, it's really easy for bacteria to go there. And then that leads to recurrent ear infections, and it can also lead to permanent hearing loss. And as you can imagine, if the mouth has a malformation like this, there could be a lot of problems with the teeth growing in and dental problems. There's also something called velopharyngeal insufficiency, which is basically when the sphincter between the oral and nasal cavity don't close properly. So that's what leads to that lack of ability to create suction and to create consonants. And there's certainly a psychological aspect to cleft palate. You can imagine a child who has cleft palate, they can get bullied or they can have self-esteem issues, body issues. They might not develop typically as other children would in terms of speech and also cognitively and emotionally because of the cleft palate. Next slide, please. The treatment is pretty straightforward. You can really only do surgery to fix it. And depending on what kind of cleft palate it is, how severe it is, what resources you have, you usually need a team of specialists. So it could be ENT, plastics, oral surgery. Speech pathology needs to be involved for sure to track the progress of the infant's speech and swallowing development. And of course, you need to loop in the caregivers to know what treatment would be best for the infant. And I want to talk about a few procedures in particular because I feel like it could be important if you ever go on rotation there. And like if you ever run into cleft palate, you can be like, oh, I heard about this technique and here are the pros and cons. I did want to mention robotic cleft surgery because that's kind of the newest one that's out there, but it's not widely used because it requires pretty expensive equipment, and so not a lot of places have it. Next slide, please. So the first technique I want to talk about is called the two-flap palatoplasty, and it's generally used for bilateral cleft lip and palate. The pros is that it utilizes a three-layer closure of the soft palate, and what that means is that it goes into the inner layer, which is the nasal lining, the middle layer, which is the muscle, and then the outer, which is the oral mucosa. And it also provides pretty good exposure for the muscle dissection in the palate. The cons is that, of course, with that much dissection, you're going to have a lot of scarring potentially. And also, there's a higher rate of fistulas forming. Next slide. Next slide, please. Oh, you're at Z-plasty. Okay. So the furlough double opposing Z-plasty is used for isolated cleft palate, narrow clefts, and submucous clefts. The pros is that it's a pretty good technique for lengthening, which means basically enlarging the soft palate so that it can reach the back of the throat and close that velopharyngeal space or that sphincter. And it tends to have pretty good speech outcomes for the infant. The cons is that it's technically challenging because, as you can imagine, if you look at the figure on part C, to do that Z shape can be kind of hard and technically difficult. So, and it's also not the best for wide clefts. And because that Z shape happens at the soft and hard palate junction, there's a higher risk of improper healing and scarring in that area and inflexibility. Next slide, please. The von Lagenbeck technique is used most commonly for isolated cleft palates or narrow clefts. The pros is that it's pretty simple and straightforward. It also preserves the blood supply pretty well, and there's a lower risk for fistula formation. The cons is that there's limited lengthening of the soft palate, and you may not be doing enough dissection to reposition the palate good enough. And there's also a risk of maxillary growth restriction, which is basically just the development of an underbite later on. Next slide, please. The Vo-Wardell-Kilner VY pushback is a technique used for wide unilateral or bilateral cleft palates. The pros is that it's pretty good at lengthening and there's a higher success rate of velopharyngeal closure. The cons, again, is that with more dissection, there's more scarring. And also with this technique, there is that risk of developing an underbite later on or maxillary growth restriction, and there's a higher risk of fistulas as well. Next slide, please. So now I'm going to talk about a particular paper that came out quite recently, and it's titled The Timing of Primary Surgery for Cleft Palate. So it's basically looking at whether to intervene earlier or later for cleft palate surgery, that initial surgery to fix it. Next slide, please. So this was a pretty big study that happened. It was going for several years and involved different countries. So it was derived in the UK, but they also looped in Denmark and I think Norway or different countries in Scandinavia. And then Brazil was also part of this. So it really was a multinational randomized controlled trial. And the infants that they enrolled had to be non-syndromic and have an isolated cleft palate. And as you can see in the figure, they had 235 infants who they operated on in the early intervention, which was at 6 months, and then 226 that they operated on in the later intervention at 12 months. For the intervention, they standardized the Sommerlad technique, which I'll get into on a different slide. And the primary outcome that they measured was velopharyngeal insufficiency, which again is that closure or the closure of that sphincter between the oral and nasal cavity so that there can be a proper separation between those two areas. And they used their own scoring system. They monitored speech and swallowing, and they also followed up with the kids at 1, 3, and 5 years old with video and audio recordings that were looked at by different practitioners and speech pathologists. Next slide, please. So why did they pick 6 and 12 months in particular, and why does it matter the timing of intervention? It's because some think that for earlier intervention, this could improve speech development, which makes sense in theory because if you were to fix the child's cleft palate earlier on, and let's say it's 100% perfect, then there will be less of a hindrance in terms of their speech development and their ability to do consonants and interact with others properly. And there's also some data out there that shows that velopharyngeal insufficiency at 5 years is less likely with the earlier intervention. However, the main setbacks are that it's technically challenging because a 6-month-old infant is much smaller than a 12-month infant. And of course, with the younger child, there are greater anesthesia and infection risks in surgery. For later intervention, it's thought that because the child is older and their immune system is more developed and they have larger anatomy, the surgery tends to be lower risk and better tolerated. But in theory, if you fix the cleft palate later on, they have less chance of those of developing their speech at a typical rate compared to other children. And of course, there's still that challenge of getting adequate nutrition to the infant to grow during that time. Next slide, please. So the Sommerlad technique was standardized for this trial. And by standardized, I mean that they had the inventor of this technique, Dr. Brian Sommerlad, they had him fly to these different locations that were involved in the study and personally train the surgeons that were operating on the infants here. So I thought that was pretty crazy that they had him do it himself and also get everyone on the same page for this technique because it's not a super new technique, but I guess that's was their way of standardizing to make sure that every surgeon knew exactly how to do it in the way of the inventor himself. So the pros for this technique is that there's limited dissection of the hard palate, so less damage is going there. There's less scarring, there's less midface hypoplasia and fistulas, and there's less chance of requiring a secondary surgery to correct velopharyngeal insufficiency. And it's pretty good for fixing wide palates. The cons is that you get a straight midline scar, which makes the soft palate less flexible. And you do need an operating microscope, which can be kind of complicated to use. And their fistula rates are up to 15%, which is middle of the road compared to other techniques I've seen. And for some reason, there's also a higher risk of ear infections with this technique because there's a higher chance of damaging the tendon for the tensor palatini muscle. Next slide, please. So the outcome of the study, the main one that they looked at again was velopharyngeal insufficiency. And they found that in the 6-month group, so the infants who had been operated on at 6 months of age had a rate of 8.9%, whereas in the 12-month group, they had a rate of 15%, which means that the 12-month group, they were more likely to get velopharyngeal insufficiency after their first surgery. The secondary outcomes that they looked at were speech and hearing, and they found that in the 6-month group, they had a greater rate of canonical babbling at 1 year by 20.7%, which is a pretty big difference. And they also found that hearing and middle ear function was worse in the 12-month group at 1 year. However, that difference equalized by 3 and 5 years. Next slide, please. So this is just a chart that was showing the rate of velopharyngeal insufficiency at 5 years. So again, the infants that were operated on at 6 months of age had roughly 9% rate of insufficiency, whereas the 12 months had a higher rate of insufficiency. Next slide, please. So there were some complications in the study. Not every infant, but some infants had to have a secondary surgery just to fix any adverse outcomes that occurred. And interestingly enough, the 6-month group, when they needed secondary surgery, it tended to be for VPI correction. And then for the 12-month group, it tended to be for some sort of fistula complication correction surgery. And as for limitations, there, of course, because you're involving so many different sites, so many different surgeons, and even though you had the inventor himself come train you, there was some variation in the surgical procedures being done because every cleft palate presents a little bit differently. And I think every surgeon has their own way or their own idea of how to fix it ideally. And the authors also wanted to include many more infants, but it was found later on that they had syndromes like Down syndrome, for example, or they just weren't medically fit to undergo a procedure. Next slide, please. So this is just a little excerpt of the conclusion. So in infants who underwent primary surgery for cleft palate repair, velopharyngeal insufficiency at 5 years of age was less common among infants who had surgery at 6 months compared to those who had surgery at 12 months. Next slide. Yep, and that's my presentation. Does anyone have any questions?
I actually have a question. Yeah, this was a fantastic presentation and it was really informative, very thorough, very well presented. I was just wondering, like, for, I guess, the technique that they chose, because it had, you mentioned like so many complications, like, why did they choose that specific technique as compared to, I don't know, the other ones that you mentioned in the beginning?
I think it's because they were only looking at infants with isolated cleft palate. And usually it seems like a lot of the infants had like smaller cleft palate deformities, like mostly involving the soft palate. So maybe that technique is best to treat that because it doesn't need to go to the gums or to the lips or to the nose in any way. That's my thinking, but I'm not totally sure.
Okay, yeah, that makes sense. Yeah, thank you.
Okay, I think that's all the questions. So thank you for all of you who came and watched our presentations. It meant a lot to us, and we hope that you learned something today.